Hey y'all, Dr. Maynard here. I'm excited to finally announce the launch of the long-awaited Aubrey Fire pre-hospital blood program. This has been a long time in the making, and a lot of research has gone into this program to make it successful. This program keeps us on the cutting edge of patient care. Now, over the past few years, we have raised the level of care in our community by adding new tools such as pre-hospital ultrasound, pre-hospital antibiotics, ventilators, and the EPOC system for pre-hospital labs. Now we turn our efforts towards a new goal of treating hemorrhagic shock, whatever the cause, whether it be from trauma or GI bleeding or OBGYN bleeding. So we need a new tool, and that tool is pre-hospital blood. Now let's start with the case. We have a rollover MVC on Highway 80. There's a 35-year-old female who's unrestrained and partially ejected from the windshield. Her leg is trapped under the dashboard. The injuries we can see so far is that she's got an open fracture to her right femur and she's got pulsatile bleeding, probably from her femoral artery. She also has some abdominal bruising. Now, she's initially alert, but quickly becomes confused, pale, and diaphoretic. Her vital signs, we can just feel a pulse, and she's got a thready pulse, but she's got rapid, shallow breathing. So, what's your plan? We'll come back to this later. What are our objectives? We want to explain why pre-hospital blood is a good idea. We also want to review hemorrhagic shock. We're going to go through the literature of pre-hospital blood. And then we're going to get familiar with the terminology of blood. We want to understand the complications. Once we have a new tool, we need to know how to use it and manage the complications. And just to note that the equipment, how to use the equipment, the protocol, how to go through the protocol, and all the logistics are going to be covered in separate training. So before we get too far into this, I want to thank the folks that have gone ahead of us, such as Parker County, Frisco Fire, and McKinney Fire. They've all been implemented and helpful for our program. And so we want to give them credit for sharing their knowledge. So some of you may ask, is this really a good idea? Well, several academic groups say yes. In a joint position statement by the National Association of EMS physicians, and of course, the American College of Surgeons and American College of Emergency Physicians. So we have EMS physicians, we have trauma surgeons, and we have ER physicians all agreeing that pre-hospital blood is a good idea. So I've summarized it here. They go through how to manage hemorrhage for pre-hospital blood. They mention that, of course, exsanguination is a leading cause of preventable pre-hospital trauma death, with nearly half of these occurring in the pre-hospital setting. So they recommend that, of course, for external hemorrhage, that we use direct pressure or a commercial tourniquet. And if it's a non-compressible site, such as on thorax, to use hemostatic gauze or wound packing. This is not a new idea, but what is new is that for hemorrhagic shock, they do recommend to give pre-hospital blood. And this is preferred over crystalloids, such as normal saline and LR. And we want to prioritize low titer type O whole blood, and we'll get into what that means later. So when somebody dies of a traumatic cardiac arrest, as opposed to medical cardiac arrest, what do they die from? Well, about 55% of them die from hemorrhage. They essentially bleed out, either internally or externally. Another 13% die of hypoxia or asphyxia. 10% die of a tension pneumothorax, and another 10% of cardiac tamponade. Now, for tension pneumothorax, we know how to deal with that. We can dart the chest, or if possible, do a finger thoracostomy. Cardiac tamponade, we can do pericardiocentesis. Hypoxia, that's easy. We can give them oxygen or intubate. For hemorrhage, we really don't have a lot. We need to get them to the hospital, to a surgeon, so we can fix the internal hemorrhage. If it's external hemorrhage, of course, we can fix that. But we really don't have anything to replace what was lost. So you can see that for the majority of patients, we don't have an adequate treatment. Now, the different types of hemorrhage, of course, like we talked about earlier, if it's on an extremity, it's compressible, we can do direct pressure or a tourniquet. If it's on the trunk, the abdomen, the back, the chest, it's non-compressible site. So we can pack that wound, we can give TXA, and soon we can give pre-hospital blood. Of course, we want to transport that patient and get them to the OR. So who's already doing this? Well, about 250 ground EMS agencies are doing it as of today. And that's only roughly about 1 to 2% of all US EMS agencies. Now, in Texas, we see clusters in San Antonio where they were the first to start pre-hospital blood. We also see some in Houston and, of course, the DFW area. So basically in the major cities. In the DFW region, we have a few. We've got Parker County, Fort Worth, Arlington, Dallas, Frisco, Saxe, and McKinney Fire, and soon Aubrey Fire. So who should get blood in the pre-hospital setting? Well, basically patients in hemorrhagic shock. They're losing blood. That's what's causing the hemorrhagic shock. So we're going to give them that blood back. It's really simple when you think about it, but we can split that into three different categories. So number one, trauma patients. And we can kind of further divide this into internal and external. While external bleeding is really easy to spot. We see the blood on the ground. We can put a tourniquet on it. We can put pressure. Internal bleeding is a little bit harder to spot, and we'll talk about that more later. The second category is going to be GI bleeds. So think about that cirrhotic patient with the esophageal varices who's vomiting massive amounts of blood. Perhaps you even need to take their airway. This is a really sick patient. Anybody who's seen one of these knows that. Also, lower GI bleeds. So when they're having massive amounts of melena, perhaps they're on a blood thinner such as Eliquis, those patients can get really sick really fast and may need pre-hospital blood. Also, remember, postpartum hemorrhage is a major cause of needing pre-hospital blood. And so these are the three major categories: trauma, GI bleeding, and OBGYN bleeding. And we do know that in about 50% of our patients that are going to get blood are actually medical. So options number 2 and 3. We always think about trauma as needing blood, but it's actually the patients, it's about a 50-50 split between medical and trauma. Now, some may say, do we really need to give a blood in the field? What if we have a trauma center that's nearby? Is there any benefit to giving blood before we get to the hospital? Why can't they just give it at the hospital? And I will say that I think there is, and I'm hoping to convince you of that with some of the literature that comes later in this presentation. Some of you also may ask, hey, is the juice worth the squeeze? I mean, this seems like a lot of work to maintain this blood, to keep it cool, and managing all the equipment. And I would say, yeah, it is. If you're that patient, you probably would say the juice is worth the squeeze. Another opposition to this is that, this sounds very complicated, learning about blood. But I would say that if paramedics can recognize sepsis, which is actually really complicated, and give pre-hospital antibiotics and manage a sepsis patient, we can recognize hemorrhagic shock. All right, so let's look at our performance at Aubrey Fire. Our code 3 transport times, our scene time is about 15 minutes for critical patients. Our transport time is on average about 29 minutes, or let's call it 30 minutes to round up. So that's about a total time of about 45 minutes that we're with the patient that we have to intervene. That's a good amount of time for a patient to decompensate due to the nature of our response area. Of course, this doesn't count the time when the patient is injured and then, or they develop symptoms because we don't have any contact, we don't have any ability to control that. All right, so let's get back to our case. So we have our MBC, and so we got to have an approach to this trauma patient. So I like the ABCDEs, and so airway's intact, her breathing, she has equal breath sounds. We don't think this is a pneumothorax. We place a tourniquet to her right leg, stop the bleeding. And disability, her GCS is 6, probably because she's lost a good amount of blood at this point. Her pupils are equal. There's no signs of a head injury. Exposure, we don't see any other injuries. So extrication, unfortunately, takes about 15 minutes to get her out, during which that time, she's decompensating. So now her heart rate is pretty fast. It's 125. Her blood pressure is low, 60 over PALT, but she's still satting well. So our biggest challenge in trauma is really time. Patients decompensate in minutes, not hours. So we really have to act quickly, and we really have a perfect opportunity to intervene in the pre-hospital setting because we're there when the patient has the problem. Now, I would ask you, what is the difference between a campfire and a forest fire? I would argue it's time. If we let things get out of control, it's really hard to get back under control. Now, if your only tool to treat this fire is a bucket of water, when do you want to use it? Early on when things are under control, or later when things are out of control? Now, what's the difference between compensated shock and death from hemorrhagic shock? I would say, again, it's time. And if your only tool is a unit of whole blood, when do you want to use it? Early, when the body has reserves and might be able to clot off the bleeding, Or do you want to wait until later when endothelial injury and multi-organ dysfunction has developed? If we wait too long, our unit of blood, our tool, isn't very effective. At this point, we need MTP, and the patient is going to need a lot more blood than if we had given it earlier. In EMS, we are used to fighting against time. This is not a new concept. What do we call it when we have local ischemia in the myocardium? Well, we call it a STEMI, and we say time is muscle. We want to act fast. What do we say when there's local ischemia in the brain? We call it an ischemic stroke, and we say time is brain. Now, what would we say if there was ischemia throughout the whole body? This is called hemorrhagic shock. You can see that every organ system is involved now. So really, we should call this whole body ischemia. Now, some of you are familiar with the trauma triad of death. I like the term the trauma spiral of death because that's really what happens. You go down the spiral. So when somebody starts to lose blood, of course, they become hypotensive. And the body compensates by increasing the heart rate and blood pressure. Now, this unfortunately increases lactic acidosis, and we start to enter the spiral down at the lower right, lactic acidosis. This decreases the heart performance, which then lowers the body temperature, and that decreases coagulation. We know that patients that are cold in the setting of trauma start to bleed more, and that produces a blood clotting problem, which we call coagulopathy. This leads to a further increase in lactic acid, and down the spiral we go. Now, in the past, a traditional treatment would just be to give this patient normal saline or crystalloids, such as lactate. This can expand the volume. It's really a short-term benefit because we can give a little bit of volume, but unfortunately, this is not a long-term solution. The problem is that saline and lactated ringers, crystalloids, don't have any platelets. They don't have any coagulation factors, and they don't have the ability to transport oxygen. So it causes dilutional coagulopathy. So what should we do? Well, we should replace what was lost, which is, of course, whole blood. And don't forget to warm the patient. Now, in the past, we've had a lot of literature from the military setting, but in recent years, we've had more literature from the civilian section. So let's look into the pre-hospital blood literature and see what this has to say. I'm going to summarize the most pertinent literature on pre-hospital blood over the next few slides. First, we have the Watts study, which was back in 2019. This was a pig study, and they wanted to look at the effect of closed chest compressions or whole blood or saline for pigs that went under traumatic cardiac arrest. So they took 40 pigs and they divided them into these 5 groups. So here's how the study went. In phase 1, they bled out these pigs, a controlled exsanguination until they got a MAP of 45, which is about 30% of the blood loss. That was considered the injury. And then they held them at that MAP for about 60 minutes to simulate shock so they could undergo all the endothelial dysfunction that goes along with shock. Then they bled them out even more until they got a MAP of 20, which of course caused cardiac arrest, specifically hemorrhagic shock cardiac arrest. And then they randomized them into 3 cycles of resuscitation in one of the following groups. So group 1, compressions only. Group 2, whole blood only. Group 3, normal saline only. Group 4 had a combination of whole blood and compressions. Group 5, saline and compressions. And then they looked at who did what. And what we see is that all subjects in the compressions group died. All subjects in the whole group actually survived. And you think about the nature of the injury was losing blood. So replacing that blood actually made the difference. This patient did not, or this pig did not need compressions. This patient needed blood. Resuscitation and whole blood uniformly improved the outcomes over normal saline. And then what we found is that anytime we gave compressions, this had a detrimental effect, and that compressions, even in the groups that had saline and blood, had a more significant metabolic acidosis, which reflected the tissue ischemia that the compressions were helping to cause. So the bottom line is that whole blood helps and chest compressions harm in the setting of hemorrhagic shock. Now let's move on to a human trial. This is the Pamper trial, and this was a pretty famous trial. They looked at hypotensive patients in the setting of trauma, and this was an air medical or a helicopter EMS. And these patients either received crystalloids, they received plasma, they receive PRBCs or the combination of PRBCs and plasma. And we can see that the combination of PRBCs and plasma is the best trend line. They had the best mortality, and crystalloids had the worst. And why? Well, obviously, crystalloids, again, don't have clotting factors or O2 carrying capacity. So we're replacing what was lost. So PRBCs and plasma came out on top. The bottom line is that blood is superior to saline in the setting of hypotensive trauma patients. All right, now we're moving on to the STAMP trial. This was in JAMA in 2021. We looked at TXA versus placebo for hemorrhagic shock patients in ground EMS. So this is the type of patients that we see. And we looked at and we saw that TXA actually didn't reduce mortality very much at 30 days, but it did show some benefit in severe shock, especially if we gave it early. Furthermore, TXA did not cause terrible clotting in the body. It just stabilized the clot. So we could say that TXA was safe. So the bottom line here is that TXA is safe and it does benefit in severe shock, but just remember to give it early. All right, and now the most important article that we're going to talk about. This is a secondary analysis of the PAMPER and the STAMP trial. And they came up with this new term called TERI. This is the time to early resuscitative intervention. So what does that mean? That means that if we intervened in the pre-hospital setting, the time from injury until we intervene in the pre-hospital setting, whether that was giving blood or TXA or applying a tourniquet, or if there was no intervention in the pre-hospital setting, that just meant the time from injury until we got to the hospital. And this is pretty amazing. What they found is that every 1 minute delay in intervening, or TERI, was associated with a 2% increase in mortality. So the bottom line is every minute that goes by, we lose about 2% of our chance of survival. Pretty significant. So let's look at our transport times. So remember, we've got at Aubrey about 45 minute total time with the patient. If we're not intervening during that time, the chance of survival is essentially zero, or in other words, 100% mortality risk, because after about 30 minutes, the average hemorrhagic shock patient is not going to survive. All right, so here's a summary of all the studies. So remember the Watts-Pig study, hemorrhagic shock, whole blood helped, closed compressions harm. The PAMPER trial, we know that blood is superior to saline for hemorrhaging patients. The STAMP trial, TXA is safe, beneficial in severe hemorrhage, but best when given early in less than 2 hours. And then the DEED, of course, every 1 minute delay, we get 2% mortality increase. Now let's change gears. Blood transfusion medicine can get pretty complicated pretty fast. So let's try to simplify what we need to know. When you draw blood out of the vein, you can spin it down in a centrifuge and it can separate into the component parts. And we can see that it can be separated into 3 different main categories: plasma, platelets, and PRBCs. We can take that and separate it into different bags. And this is what we call component therapy. And you can see PRBCs are just the oxygen carrying capacity. Platelets are the first step of clotting. And then FFP, fresh frozen plasma, is the second step of clotting. And that involves all our clotting factors. So with component therapy, it's pretty common in hospitals. This is typically what we do in the ER when somebody has needs a blood transfusion. We give them just a PRBCs, just the red blood cells. So you can see it has the PRBCs, the oxygen carrying capacity, platelets, first step of clotting, FFP, fresh frozen plasma, contains the clotting factors in the second step of clotting. MTP is what we use sometimes, and this is where we combine all 3 of these bags and basically simulating whole blood. This is when we're giving patients their entire blood volume, or commonly greater than 10 units of blood in less than 24 hours. And we give it in a 1-to-1 ratio. That means PRBCs, platelets to FFP. Whole blood, you can see on the right, is all in one bag, whereas component therapy in that 1-to-1 ratio, we're giving 3 different bags. So it's much more complicated. Whole blood's an all-in-one resuscitation. It's minimally processed, so only leukoreduced, meaning they reduce the white blood cells, and then they add an anticoagulant, which is citrate, and we'll see how that can become an issue later. The benefits is that it's just one bag. It's very simple, easy to hang, easy to monitor. It's got all the oxygen delivery capacity and all the clotting capacity. And unlike FFP, we don't have to thaw out the FFP because whole blood has all the clotting factors, but doesn't require thawing. Also, it's from a single donor, which means that there's less exposure from multiple donors into different bags in terms of risk of HIV or hepatitis. And again, it replaces exactly what was lost. All right, we have different blood types. We've got the ABO system, and this is named for an antigen, or basically a protein that's on the red blood cell. Antigen is a surface protein. It's a way to recognize the type of blood that it is. There's four different groups. There's A, there's B. You got the combination of A and B. That's called AB. And then you have no antigen. That's called O. There's also an RH or D antigen, and that is a separate antigen that's present or it's not. Either you've got it or you don't. And so we say if you've got it, it's positive, and if you don't have the RH, you're negative. So let's do an example. If you had type O of the ABO, you're type O, you don't have any of the ABO antigens. And then positive means that you have RH positive. All right, so the antigens are on the surface of the RBCs. The antibodies are made by the immune system to attack pathogens, including these antigens on the blood. So an antibody attaches to an antigen like a lock and key. The ABO antibodies occur naturally. We're born with them. For some reason, we've got antibodies against other people's blood types. So an example, if you have type A blood and you're born with antibodies against the B, we call those anti-B antibodies. So if you have type A blood, you can receive only type A or type O because O has no antigens on the surface of the red blood cell. Now, there's different blood types, and in the population, they occur at different levels. So type O positive is actually the most common. About 38% of people have O positive. And this is great because it's easy to get donors for this type of blood. All patients can receive this blood, but it may be a problem if you're a pregnant female who's Rh negative. We'll talk about that more in a bit. O negative is the universal donor, and this has the least risk of transfusion reactions because there's no antigens whatsoever, no ABO antigen and no RH antigen. It has no antigens when it's O negative. The problem is that this is really rare. It's only about 7% of the population, and so it's hard to find donors. It would be great if we could only carry O negative blood, but the problem is that there's not enough donors to support any system with pre-hospital blood using only O negative. All right, we've got to talk about ABO compatibility. So this is when a blood is exposed to the patient and it causes hemolysis. Hemolysis basically means the blood is lysing or breaking open. It's a destruction of the red blood cells by the immune system, by those antibodies we were just talking about. So let's do an example. If a patient is type A, they have anti-B antibodies. Then accidentally they receive type B blood into their body. Their immune system, specifically those anti-B antibodies, are going to destroy that donated type B blood. And that's going to cause what's called an acute hemolytic transfusion reaction. And this is actually a really big deal. This is deadly. Those cells are going to rupture, cause hemolysis, and this is going to cause a cascade of an immune response that can become very, very deadly and lead to things like DIC. All right. The universal donor is O negative. They have no AB, no RH antigen, so it's safe for everybody to receive. The problem is that it's rare and it's hard to get donors. The universal recipient, this is the patient you want to be because you can receive any type of blood and this is not going to be a problem for you. You don't have any antibodies against AB or RH because you have both of those antigens on your blood. So they can receive any type of blood. So we've been speaking about RH, but just to go over it again, unlike the ABO system, this anti-RH antibodies are not naturally occurring. You have to be exposed to them first. This is how the immune system normally works. You get exposed to something, you develop antibodies, and then now you have antibodies moving forward. So after an exposure, typically in two ways. So you can either get a transfusion of RH positive blood and the patient was RH negative, Or there's an Rh negative mother who then has a pregnancy with an Rh positive fetus, meaning that that fetus probably got the Rh antigen gene from the father and now has Rh positive blood in the fetus. And so mother is Rh negative. If her immune system sees the Rh positive, it's going to attack. All right, so if the Rh negative mother is exposed to Rh positive blood, there's going to be hemolysis. The mother's immune system essentially attacks the fetus. All right, so let's talk about some complications now. Let's do a case. You have a 30-year-old female who's 35 weeks pregnant, so pretty far along, and she starts to have massive vaginal bleeding, about 1 pad per hour, which is pretty significant. She's lost a good amount of blood. We can see that because her blood pressure is pretty low and her heart rate's pretty high. This is what we call a bad shock index. She ends up getting 2 units of O positive pre-hospital blood and goes to the ED. OB takes her upstairs, does an emergency C-section, saves the baby, and notices there's a placental previa. So the patient and the baby survive, so this is great. High fives all around. And then later we test the mother's blood and we find out that she's Rh negative. Oh, so that's a problem now because we've given Rh positive blood to the mother. So what's the risk? We could cause what's called Rh alloimmunization. This is when an Rh negative mother develops anti-Rh antibodies after exposure to Rh positive blood. So that's either from our transfusion. So the risk is really not with that current transfusion, but it's for future pregnancies. So the mother's anti-Rh antibodies may attack the fetal RBCs if they are Rh positive. This is generally low risk. Now, females who are Rh negative are only about 10 to 12% of the population in DFW anyway. And Yazzer found that this would be a problem and cause significant death or morbidity in only about 0.3%. So if females are Rh negative, they may need what's called RhoGAM. This is another antibody that then binds and covers up the Rh so that the immune system cannot see it and respond to the Rh antigen. It's a medication that essentially hides the Rh antigen from the mother's immune system, so mother does not create antibodies. But remember, keep perspective. The bottom line, if a patient is in hemorrhagic shock, they have a really high risk of dying from hemorrhagic shock. So we don't want to get caught up in the details of whether the patient is Rh positive or not. If they're sick and they meet criteria, we're going to give them a blood transfusion, and later we can figure out the details if the patient is Rh negative and then give them RhoGAM in the hospital. Remember, always look at the risk and the benefit. A patient could literally die from hemorrhagic shock. We have the opportunity to save their life. We don't need to worry about the Rh issue until later. All right, let's move on to transfusion reactions. This seems like a lot, so we're going to try to break it down and make it simple. The first and most common is a febrile non-hemolytic transfusion reaction. So the causes is basically cytokines from the donor's white cells that are in the blood and the donor leukocytes. So this happens right away, and we see mild fever, maybe some chills, but there's no hemolysis. Basically, we just give antipyretics such as acetaminophen. It's pretty rare, but still the most common of the transfusion reactions. Now, number two is actually life-threatening. This is an acute hemolytic transfusion reaction. This is when we gave the wrong type of blood to a patient. Now, this shouldn't happen if a patient is receiving type O blood, and that's all we're going to carry. So this is the ABO incompatibility, and it's very severe. So this happens right away, and the patient's going to have fever, chills, maybe flank pain. They may have dark urine. They may become hypotensive. That's one of the key distinguishing features. They may start to have symptoms like DIC, where they're bleeding from their IV site, and they may go into renal failure. This is a sick patient, whereas number one, the non-hemolytic transfusion reaction is not a sick patient. We want to stop the transfusion right away, and then of course we're going to do fluid resuscitation and conservative management. Another is an allergic reaction or anaphylaxis. Now, this is caused by the recipient's IgA response to the donor plasma protein. So it's basically the donor is the recipient is responding to proteins that are in the blood they're receiving. This happens right away, and we know how to spot this. These are just hives, itching, maybe some bronchospasm, some wheezing, potentially some hypotension if it's severe. We call that anaphylaxis. And we know how to manage this. We just give antihistamines, we give steroids, and if it's severe, we can give epinephrine IM. Another transfusion reaction is TRALI, or transfusion-related acute lung injury. Now, this happens usually within 6 hours, and this is basically like ARDS, or acute respiratory distress syndrome, after a blood transfusion. This is where patients get bilateral pulmonary edema and they get fever. This is basically supportive. We try to avoid diuretics. The severity is high, but thank goodness this is very rare. And then last, we have TACO, or transfusion-associated circulatory overload. And this is basically we're giving volume to a patient who has trouble managing volume, such as your end-stage renal disease, your CHF patient. So if you give them any type of blood volume or any type of saline, they're going to have volume overload and potentially develop pulmonary edema. All right, so how common are these reactions? Well, we talked about the febrile transfusion reaction, the first one. This is the most common. This is only about 4%. So you have to give quite a few blood transfusions before you ever receive one of these. Allergic reaction is the next most common, and that's actually less than 1%. And the others are even more rare than that. So remember, transfusion reactions are rare. The most common is just a mild fever, a non-hemolytic response, and we just give acetaminophen. Allergic reactions are the next most common. We see itching, urticaria, and we know how to manage this. We do this very frequently. And if they're really sick, we can give EpiIM. For the life-threatening acute hemolytic transfusion reaction, this should not occur if we're giving type O blood, but if it did for some reason, we would stop the transfusion. Let's talk about hypoglycemia. This is a common problem when giving lots of blood to a patient. So let's talk about why. Now, blood, when it's in a bag, has a tendency to clot because calcium is involved in clotting. So we can put a blood preservative called citrate into the bag of blood, and this will bind up the calcium. The problem is that it will continue to bind calcium when we give it to the patient. So citrate in the whole blood may cause hypocalcemia in the patient. So this is because we're giving the blood that contains citrate to the patient, and then in the patient's blood, it's going to start to bind up that patient's calcium. And this will happen usually after about 4 units. But as a precaution, we're going to go ahead and give calcium to any patient who's giving pre-hospital blood. When you give blood, you give calcium as well. Let's talk about patient consent. Patients who have decision-making capacity, they should receive informed consent. You just read this to them. We believe the patient has a life-threatening hemorrhagic shock, which is poor blood flow to vital organs. And the benefit of blood transfusion outweighs the risk. The risk include an allergic reaction or transfusion reaction, and even transmission of disease such as HIV or hepatitis. But the risk of obtaining a disease is about 1 in a million. Do you consent to transfusion? If a patient cannot make decisions, we will become their decision makers, and that's what we call implied consent. Also, remember that if a patient has a religious exemption, such as Jehovah's Witness, we want to try to manage that, possibly call medical control, make sure they understand the risk of not receiving the blood transfusion. All right, so what are we going to give patients at Aubrey Fire? We're going to be giving low titer type O whole blood. What does that mean? Low titer means that it's low levels of those anti-A and anti-B antibodies, and this is going to minimize the risk of a transfusion reaction. And we're going to give type O because it's a universal donor. Usually it's going to be Rh positive. Typically, we're not going to be able to get Rh negative or O negative blood. Whole blood contains everything we need for oxygen delivery and clotting, so that's why we're hoping for whole blood. At times, we may need to do a backup of PRBCs only, just the red blood cells. When we store it, it needs to be stored at 1 to 6 degrees Celsius in the cooler, and the shelf life is about 35 days at the maximum. It's about half a liter of fluid, And with the right pump and warmer system, we can get this into the patient in less than 3 minutes. The cost of whole blood is about double that of component therapy. So, some take home points. Exsanguination remains the leading cause of preventable prehospital death. Prehospital blood is part of that solution, in addition to all the things that we normally do, like controlling bleeding, like managing the airway, like doing finger thoracostomy and pericardocentesis. But now we have an extra tool. Remember, every minute that we delay intervention, that patient loses 2% of their risk of survival. Some people want it to happen. Some people wish it would happen. Others make it happen. Let's go make it happen.